A very good evening to all the wonderful attendees, our 156 people who are already here, who have, many of you have joined earlier to 8 p.m. and I'm extremely overwhelmed. And we welcome you all to this active learning classes of Tuesdays with Teachers. Well, this is a small dream, and it is because of the continued support of all of you who are joining in every Tuesday that we are energized and raring to go. Today's session, actually, normally it's my moderators who introduce the session, but because my moderator has very important job to do, so I'm just going to give a small overview of this today's session, which is on second stage. Well, the guidelines say that we can wait for 2 hours, 3 hours, etc., etc. But what I feel is in practice, when we have to translate it, we have very limited time because the anxiety level of the patient, the relatives, and the obstetrician is all at stake. So in today's 90-minute session, 1.5 hours, we have been over ambitious. We're trying to cover second stage. We are trying to get something new, a dream of alternate birthing positions to see it in reality. And of course, to address those questions at the end, which normally an obstetrician forgets to even mention. So, Raina, can you please show me the slides? I want to introduce the moderator for today is Dr. Raina Chawla. Please take it off. I am Dr. Mitra Saxena. You all know me very well. So our speaker for the day is Dr. Mumtaz. She's a professor and HOD from Perinthalamanna city. She's a HOD of a medical college, and she is in Kerala. And then extremely fantastic. When you look at her PPT and her discussions, you will be fida. And then next speaker of mine is none other but my very good friend, Dr. Bangal. Next slide, please. Dr. Vidhyadhar Bangal is HOD of Prevara Institute. And well, he has impressed many of us with his, wonderful talk on alternative birthing position. But why I have included Sir is because I have actually had the opportunity to go and, see his institute, and I can say it without any, confusion that his is one of the best obstetric units in the country. And I'm not exaggerating it because he has made some dreams actually come true. And in his session, I'm sure he'll show you how it's done. So, and my moderator, please show the slide of Dr. Raina. Dr. Raina.
My slide is just.
You haven't made your slide. Where is it?
Actually, I thought I am a small fish in the sea
Let
of
me speak. Let me speak about you.
So
Dr. Raina Chawla is a young, extremely brilliant consultant working in Faridabad, but multitasking. In addition to her practice, which she's doing fantastically well, she's also into teaching. And I've been associated with her because she's a member of my practical obstetrics committee. I'm extremely grateful to God and to these wonderful people. I had the opportunity to listen to Dr. Mumtaz when I was in Kerala. I have been fortunate to collect these, guests and diamonds for all of us. So over to you, Raina. You please set the ball rolling. I started at 8:02 and it is 8:07. So my 5 minutes are over. And over to our speakers and moderator, Dr. Raina.
So thank you so much, ma'am, for this session. We are now in the 7th edition of Tuesdays with Teachers, and I am very honored to be able to moderate this session with ma'am. Is our visionary convener of this session.
That's fine. That's fine, Dr. Raina. Ma'am has already introduced us.
Active.
Yeah. Ma'am has already.
So we'll start with the session. Yes. So we'll start with the session. Dr. Mumtaz, over to you. So Dr. Mumtaz will be covering second stage problems. And without further delay, let's start, Dr. Mumtaz. I'll just stop share. You can share your screen.
Okay.
So while Dr. Mumtaz is actually setting her stage, I just want to tell you that it is a reiteration of things which already we know, but in a very nice, explicit way, something new which all of us can learn. And of course, how to manage things so that we are, at the end, we are happy with a healthy mother and baby. Over to you, Dr. Mumtaz.
Thank you, ma'am. Thank you for this great opportunity. So, coming to the second stage management. This is something we all want to see the next day after conducting a delivery or doing a cesarean, but sometimes the things are not so. So, we are looking into certain topics here today. That is how to monitor the second stage, how to diagnose arrest, and how to manage it, and role of ultrasound in second stage. When we have a problem in second stage, first thing that comes to our mind is cesarean section. But now we know all of us are auditing cesarean section because we know the complications like accreta, scar ectopic is increasing, and also the intricacies with VBAC. So hence, even the government authorities are against increasing cesarean section rates. And we as obstetricians ourselves are aware of cesarean, the impact cesarean has on obstetric outcome of the patient. So when we have a patient, like this is the old pathogram, where we know this patient is in labor for quite some time and she finally undergoes cesarean section to deliver a 4.6 kg baby. But here we can see for quite some time, there was no descent. There was no further cervical dilatation. And in spite of very good uterine contractions, as you can see here in this black marked area. But what has happened by then is that the fetal heart rate has dropped. Fetal heart rate is dropped. So we all talk about watchful expectancy and timely intervention in obstetrics, but this definitely is not watchful expectancy. We need to diagnose arrest. It can be arrest of dilatation, arrest of descent after full dilatation. I put arrest of dilatation in relatively lighter shade because when there is arrest of dilatation, we have no choice. We end up and in spite of good uterine contractions, if that is happening, we end up doing a cesarean section. Arrest of descent, again, if everything is okay, if the cervix is dilating at an okay rate, then we wait. Okay, but even after full dilatation, when arrest happens, we tend to do certain things which can really harm our patient and even ourselves. So arrest after full dilatation is a very tricky situation where sometimes we think we can take out the baby with an instrument, but that can end in real complications, including rupture of the uterus and a stillborn fetus. So all these things do not happen like a lightning that is happening all of a sudden. There are actually certain pointers. In this story, we all love the tortoise, but here not so. When we know there is a slow progress, that itself is a first indicator that we could be having problems in the second stage. And when we do pelvic examination, we do the diameters and curvatures, of course, that is fine. And after that, what do we look at? We look at the cervix and the presenting part. In cervix, we look at the dilatation and the station. Most of us sometimes stop with this, but that is not actually not enough. We should look at the thinness, whether it is stretchable and whether it is well applied to the head or not. A loose hanging edematous cervix, which is not stretchable, again is a bad point. And regarding the presenting part, it is not just the station. What is the position? Whether there is caput and molding and whether there is asynclitism. In addition to looking at all these things, we need to keep reassessing during our next pelvic examination. What has happened to the caput? It is increasing. What has happened to the asynclitism? It is corrected or it is remaining the same. So now when we talk about this dilatation, we have this new WHO labor care guide, which clearly says at each cervical dilatation, what is the permissible time for us to wait? That is, after 9 centimeter, we can wait even two hours for it to become fully dilated. So WHO labor care guide is totally different topic. We are not discussing that now. Now, after imagine the cervix is dilating in normal rate, but head is low, but she's not delivering. The question that we need to ask ourselves is that, is it really low? These are two things which will make the head look lower in addition to caput and molding. These are two things which will make the head appear lower, but it actually is not. Assessment of descent can be quite tricky in the presence of an edema, caput, or if the patient is not very cooperative, especially in a primis. But we have this beautiful method of assessing it by doing this method, whether it is palpable per abdomen, how many fifths are palpable, whether both poles are palpable, whether it is a flexed head, whether there is a deflection or it is going for extension. All these things are important. It is not that you just assess a woman in labor by per vaginal examination. You have to always do this assessment also to have a correct idea about descent. Asynclitism, we might think that it is something very theoretical, but this point is something we have to always keep in our mind. When we do a per vaginal examination, the first thing we all try to feel is a sagittal suture. Where is the sagittal suture here? We don't have to know what is the name of the asynclitism and all that, but the sagittal suture is deflected anteriorly, and it is a posterior parietal bone that we are feeling here. And in this situation, it is reflected posteriorly, and it is the anterior parietal bone that we are feeling when we do the pelvic examination. We have great difficulty in feeling the sagittal suture. We have to either move towards the pubis or move towards the sacrum to feel the sagittal suture. So that means the head is in a tilted position. Asynclitism is actually a method adopted by the fetus to enter the pelvic inlet. It is actually moving its head sideways to enter the pelvic inlet. But once in the cavity, it has to get corrected. It has to be in synclitism in the cavity. If that doesn't happen, it is suggestive of either a mid-pelvic contraction or a relatively larger head for that particular pelvis. So when there is asynclitism, when we see that one parietal bone is more prominent, it is deflected to one side, we should remember that it is a falsely low station, and some part of head is still palpable per abdomen. In this situation, we should never attempt instrumental delivery because that is going to cause large tears, sometimes including the lower uterine segment. Another problem we have is the occipito-posterior position, where the patient will have premature bearing down, and we'll also feel that head is down. But it is a larger presenting diameter here, so it is not that easy for the head to come down. But if you diagnose occipito-posterior in the beginning itself, we can be more cautious. Sometimes we have a wrong assessment of position. Why does it happen? We feel the sagittal suture, we move to one side, and we look for this V-shaped, green-colored V-shaped structure, thinking that that is the junction between the sagittal suture and the occipital bone, and we assess the position as right occipito-anterior, where in reality, it is actually left occipito-posterior. So to identify this, we have to feel the sagittal suture first, no doubt about it. We have to go to this V, and after that, we have to extend our finger a little more to make sure that it is the bone that is present beyond this V. I mean the junction of the sutures. Then only we can know that is occiput, and then only we should assign the position. Now this curve we all studied during MBBS and also our PG, and we very well know the stage 1 has 2 phases and all that. Now we also know there are 2 phases for the stage 2, second stage also. That is the passive phase, that is till the cervical dilatation is complete and head reaches the pelvic floor. And active phase, where actually the woman has the urge to push down because it is lower down in the pelvis towards the perineum. And how long to wait? Without epidural, they say 3 hours of pushing in primaries and 2 hours of pushing in multis. So if the fetal conditions are good, we don't have to hurry and put in a forceps and pull, put in a vacuum and pull. If the fetal condition is good, we can wait this much hours. That doesn't mean that we shouldn't interfere in between if you find there's an uncorrected asynclitism. Don't wait for this 3 hours. The uterus will rupture, the baby will become asphyxiated. If everything is fine, there is no asynclitism, no caput or a significant molding, FHS is good, we can wait, we need not worry and interfere hastily. What happens the time has passed? Beyond this time, what can we do? We have only 2 options. One is instrumental delivery and cesarean section. But before that, reassess your finding before choosing these things. Because next day, this is what you expect, and this is what you will get. My wife had whole of labor pain and finally cesarean and its burden also. So it is our secret fear or ego sometimes that would make us go for an instrumental delivery. This is something we should never do. We should keep our ego or our mind that mindset that I should complete, I should be successful in this instrumental delivery. It's not like that. A difficult instrumental delivery can cause all the tears, asphyxiated fetus. So why should you take that risk? So is there anything we know that nothing is black and white in this world. There's a gray areas, and now the gray areas are increasing. So is there a more objective way? And there comes the role of ultrasound. Ultrasound, the trans-abdominal and transperineal, it helps in identifying the position, descent, internal rotation, and extension. Position of fetal spine, as you can see, this is trans-abdominal ultrasound. When the spine is anterior, the occiput has to be anterior. So when spine is posterior, we think the occiput is posterior. That is one method. And you can see the orbits are facing anteriorly, definitely the occiput is posterior. And you can look at the choroid plexus, the thalami, the arrow sign that we all studied when we do the BPD plane. And there you can see the cerebellum also. And if it is pointing to left, that means occiput is on the left side. It is a left occipital transverse. So in this case, it is left occipital transverse, and in this case, it is left occipital posterior. Now, another area where we have a interpersonal difference of opinion is that station. Whether the head is descending or not, whether it is the caput that is descending, whether it is the asynclitism that is making it look that it is descending. So the most important test here is angle of progression. How to do it? It is transperineal ultrasound, mid-sagittal scan. You look at the angle between this red line here, hope you can see it, along the pubic bone, and drop another line at the lowest end of the present part, that is the fetal head. This angle is the angle of progression. So it is simple. You don't have to do a pervaginal examination. You do a transperineal sagittal probe. Keep the probe, your transabdominal, that same probe, keep it on the perineum. You'll see the pubic bone like this, hyperechogenic like this, and draw a line through the middle of that. And here you can see the fetal head, and that along the lowermost part of the fetal head, drop a line from the lower end of the pubis. So this angle forms the angle of progression. So as you can see, as the head descends, the progression, the angle increases. So here is a comparison between angle of progression and head station. As you can see, the angle of progression is less, the station is higher up. And when the angle of progression is 170, this is an estimate, the head is at the outlet, that is +5. Head perineum distance is another test where you keep the probe transversely. So your probe is here. This is the probe. This white line is the probe at the perineum. And this is the lowermost part. This is the bony prominence. And this is the caput. And here you can see molding also. So what is the distance between your probe and this bony landmark of the fetal skull, not the caput? So that is head perineal distance. So it will go on decreasing as the head comes down. Here you can see the head was higher up. Now the head has come down. In this picture, you can see that the head has also started rotating. So these are the two measurements, angle of progression and head perineum distance, that we can easily do. But one problem with head to perineum distance is that it doesn't take into consideration the curve of Caris, whereas angle of progression actually takes into consideration the curve of Caris, also the axis of birth canal. So that is actually better assessment than head to perineum distance. We know internal rotation is an essential and very important step in the mechanism of labor, where actually the whole story of mechanism of labor is how well the fetal head aligns itself to the different diameters of pelvis that is available. So though the head enters in oblique or transverse diameter, at the outlet, maximum pelvic diameter is anteroposterior. So head has to put the presenting diameter, that is the suboccipital-pragmatic diameter, in the anteroposterior diameter of the pelvis. So that is the reason of the internal rotation. So how do you know whether internal rotation has happened? In pervaginal examination, you look at the position. It was left occipito-transverse, then it is rotated to left occipito-anterior, then direct occipito-anterior. So by pervaginal examination, imagine if you are not able to make out the position, how will you know the internal rotation has happened or not? There again, ultrasound comes to our help. We can look at the midline angle. Here, you drop in a line from through the anteroposterior diameter of the pelvis. Just drop down anteroposterior axis of the pelvis. Then another line through the long axis of the fetal head, as if it is going above the suboccipito-pragmatic diameter. So this is the midline angle. Here you can see the green line is going in between the cerebral hemispheres, and this yellow line is the anteroposterior axis of the pelvis. So as I told you, this can, per vaginal examination, this is how we assess. And here you can see, this green line again is the line that is, this is the arrow sign here. So this is the line that is going through the center of the head anteroposteriorly, and this yellow line is from the anteroposterior of the pelvis. So this is the midline angle. So this angle should go on decreasing. Here you can see the angle is quite large, and here it is almost in same line with the anteroposterior diameter of the pelvis. So we have this newer things now to aid us in diagnosing arrest. Now, once you diagnose arrest, how to manage it? We have only two options again, that is instrumental delivery and LSES. So before instrumental delivery, again, I'm emphasizing this again. You have to see for the pulse palpable, look for uncorrected asynclitism, and look for persistent occipito-posterior, whether it is onto one side or direct occipito-posterior. And obesity, abdominal wall edema, caput, molding, or uncooperative patient will make it very difficult to assess. She is in the second stage, she's through a lot of pain, now she's bearing down. People are asking her to bearing down, somebody is trying to give her a fundal. So among all the chaos, it is sometimes very, very difficult to assess all these things. Here again, ultrasound plays a role. When the angle of progression is less than 138, it indicates the procedure could be a complicated one. What is a complicated procedure? Defined as something requiring more than 3 tractions to deliver, or a failed procedure, or a maternal or neonatal trauma following the procedure. So when the angle of progression is less than 138, that means the head station is higher up. You shouldn't attempt instrumental delivery. Likewise, head perineum distance, if it is more than 35, the incidence of cesarean section is high. And also, if the head perineum distance is more than 35, a lot of babies born after instrumental delivery were acidotic. So head perineum distance or angle of progression has to be taken into consideration if you are not able to assess through the clinical methods before deciding whether we should have an instrumental delivery or go for a C-section. And no pole palpable per abdomen, again, that can be found out through our ultrasound. Imagine what is the role of this internal rotation, the type of the instrument used. Here you can see 3 types. This is the internal rotation is complete. Internal rotation is not complete. It is but less than about 45 degrees. Here the internal rotation is not complete. It is occipito, left occipito transverse. So in these first 2 cases, we can attempt instrumental delivery provided the head is low down. I'm just talking about the internal rotation now. But in a non-rotated head, it is better to use, we all know it is better to use vacuum only. And what is the relation between position and direction of pull? Here we have 2 scenarios. This is occipito anterior, this is occipito posterior. If we pull downwards in an attempt to make the head descend more, what will happen? The neck will undergo extension, and further a larger diameter is going to present, and she's not going to deliver. It is going to take more time, or it is going to cause more deeper tears. So we should never pull downwards in occipito-posterior. The pull should be always upwards. That is to maintain the flexion and to get the minimum diameter. When to abandon the procedure if the descent doesn't occur with appropriate application and pull. And we shouldn't have this idea about achieving vaginal delivery at any cost. It's not our uterus, not our cervix, it is not our child. Like, we shouldn't take that risk on someone else. Be willing to abandon a planned or attempted operative delivery, do a cesarean section. So take the consent accordingly. In second stage, when we are in doubt, 50-50 or something like that, we are attempting a instrumental delivery, forceps or vacuum, do it in the theater after getting a consent. So it is no harm even if she delivers. And if she doesn't deliver also, we are in the theater, we can immediately do a cesarean section. So what about the cesarean section in a deeply engaged head? We know the extraction is going to be difficult. There can be tears in the lower segment, which can include bladder, sometimes even ureters also. Hematomas and PPH is common. This hematoma doesn't look very easy to manage, especially when it happens between the leaves of the broad ligament. It can extend retroperitoneally, even up to the spleen or liver, like that. And the patient is definitely going to require a lot of blood transfusion, sometimes end up in an obstetric hysterectomy, and we may have to call in a urologist. All of us don't have an access to that. And baby can be asphyxiated, sometimes stillborn, and prolonged NICU stay with its own consequences, and puerperal sepsis, risk of thrombosis also. So the simple LSCS, which we all do, and we take pride in doing that, we do it in very short time. That is also not advisable. Anyway, so that simple LSCS is converted to a complicated surgery. What about the push method? The head is low down. Can we ask somebody to push it? Who is there to push? Whom do we have there to push? Who knows the correct method to push? This is not the method to push. This is how you should push. So, but who is there? We have to actually flex the head and push it upwards. Who is available? Definitely there is not going to be another gynecologist, not even a senior nurse. It is usually the junior most nurse who is available on the floor. So if at all you have doing this push method, as Mitra madam was telling the other day, madam herself pushes the head up and gives it to the assistant perabdominally, and then madam deglouses and completes the surgery. So that is one way of doing it. Or we can do the Patwardhan method. In occipito-posterior, it is a shoulder-first method. In occipito-anterior and occipito-posterior, the modified Patwardhan. So here I am showing a video of the Patwardhan method. You can see when you put the incision little higher up, and that thing that is bulged through the incision is the shoulder. And you extend the incision with scissors on both sides. That will give you adequate, and take out one shoulder that is there. Go behind the neck, over the shoulder, the other shoulder, bring it out also, that also gently. At this point, you stand facing the head of the patient, keep both your hands, nobody is giving fundal pressure here, both hands in front of the chest, and gently pull out the baby. You are only causing flexion. There is no extension. Now you can see the buttocks are coming out. So the head is delivered. So there you can see a non-asphyxiated baby, and also you can see the lower segment is, you have to visualize the edges. You can see there are no tears in the lower segment. Imagine if you're putting your head in between this lower segment and the head and the pubic bone. This definitely there will be tears in deeply engaged head. So this is again showing the method. Take out the shoulder first. Don't be hesitant to take out the shoulder. Remember, we always have the option of extending the incision to a J. Inverted T is not advisable, but don't think that we'll be stuck with the fetus in this. It will never happen. If you put an adequate incision on the uterus, definitely the baby will come out. So take out the one hand first, go to the other hand over the shoulder like this, go to the elbow, gently flex it. That hand is also out. Once that hand is also out, the baby is actually like this, a swimmer, both hands outside. Then you should gently pull out the baby. At this point, it is important that you shouldn't be facing the abdomen of the patient. You should stand facing the head of the patient. Then only you will get that fulcrum to pull out the baby. And once the baby is out, always inspect the lower segment. And we have modified Patwardhan where you take one arm first, then the leg on the same side, then the other side leg, other arm next, then head delivery last. Where is this required? When the occiput is posterior. But one thing good about occipital posterior position in second stage is that most of the time the head is not that down. It is still up. So we can, sometimes we will be able to take it out the usual conventional method. I mean, usual way we do the cesarean. And we can also do the breech extraction, that is called pull method. You have opened the uterus, you go directly, hold the foot of the baby and pull that foot. The other foot, the buttocks will follow, and the baby will be like an internal podalic version, it will come out. So intraoperative decision. It is the intraoperative decision that which method should be used to take out the baby. If our incision, the uterine incision, is corresponding to the shoulders, it is best to take out the baby with Intrapartum method. But in case when you put the incision, you can see the head there, then it's fine. We can do the usual cesarean. There are certain tips. Pain vagina also, it's not vagina, vagina also. Jewel coin incision, that is a little higher incision is required on the skin, and that should be long enough, adequate length. Don't think about the cosmetic aspects here. Bladder will be pulled up, so separate and push down with patience. Lower segment may be thin and stretched out, but in many cases we have seen very thick and edematous lower segment also. Either the case, cutting is better than stretching because we are sure about the adequate length of the incision that we are going to get, and also healing is better. There is no pockets, there is no pockets for the hematomas, so the scar is better when you cut the uterus. Higher incision, as already told, close in 2 layers always. And after you close the uterus, exteriorize the uterus and inspect the posterior surface. That's also important because she was in labor for quite some time. We do not know whether there was any tear in the posterior side sometimes. And she requires definitely higher antibiotics and thromboprophylaxis. Now, coming to the last part of the talk is shoulder dystocia. Imagine she didn't require cesarean section, neither no Patwardhan, no convention, nothing. She progressed, she delivered, but the shoulder is stuck. When shoulder is stuck, we know about the consequences. I'm not going into the details of that. Why do the shoulders get stuck? Because shoulder fails to rotate to bring the bisacromial diameter into the favorable diameter of the pelvis. So if you think theoretically, there are many primary maneuvers, secondary maneuvers, maneuvers of last resort. We're not going into that. In this situation, when we diagnose the turtle sign, that head is stuck against the perineum, how much time do we have? We do not have much time. So what to do? First thing, if you're alone, you don't have many people in the labor room, call for help. That is very important. And somebody has to go and explain to the bystanders and get a consent. Let them know that this can end in somebody else has to do that. First thing to do is do the macrobursts, that is elevate the legs and abduct and hyperflex it onto the abdomen and give suprapubic pressure. Episiotomy, if not already given, we have to give episiotomy, and all of us are familiar with this. That is RRR, that is remove the posterior arm. Rotatory maneuvers and rollover are the usual maneuvers that is done to deliver this fetus. Yes, extending the episiotomy is important, not by thinking that the shoulder is going to come out because of that, because shoulder is not at the perineum, it is at the pelvic brim. Your episiotomy is not going to make it come down, but it is going to give you more space for your maneuvers. Fundal pressure, no. If you're doing fundal pressure, it is again getting stuck. Like those who have watched Tom and Jerry will know what happens to the Tom when he is pushed into the pipe. So that is going to happen if you give fundal pressure. So what to do next is the macrobursts plus suprapubic pressure. What about macro? How does it help? This is the first picture and this is after macrobursts. Here you can see this rotation will move the pubis anteriorly and also cephalate. So that means there is relatively more space in the anteroposterior diameter of the pelvis. It is the anteroposterior diameter of the pelvis that is important. So this is not enough. This first picture is wrong. We have to flex the knee and hyper flex it into the mother's abdomen. Then only this cephalad movement will happen. Just by flexing, there is nothing is changing here. So this is how it should be. It should be her leg should be pushed towards her abdomen, and with suprapubic pressure, we are hoping that one shoulder will be dislodged. With the new increase in the anteroposterior diameter, the posterior shoulder might come out. So some amount of push is needed here for every one of us. Like, what should be the direction of pull? When we conduct the labor, we all have the tendency to pull it downwards, thinking that downward pulling will bring the baby downward. It's not so. It should be horizontal to the table, because the more you pull down, the more will be stretched on the nerves, and the worse will be the outcome for that arm. So direction of pull should be horizontal. If this fails, what next? Then we have the delivery of the posterior hand or arm or shoulder and rotational maneuvers. How to deliver the posterior hand? Sweep it across the chest and it will come out if you're able to reach there. So this is the correct method and this is the wrong method. Wrong method is that you shouldn't push or pull onto the humerus, because that is going to fracture it. You have to either push at the elbow, or if you are fortunate enough, you can catch onto the wrist and pull it, but no pressure on the humerus. So delivery of the posterior arm, you can see pressure on the elbow has made it accessible. Once one arm comes out, definitely the bisacromial diameter decreases, so the other shoulder slips out of the behind the pubis symphysis. So when one shoulder comes out, usually the other shoulder will come out. So how to enter the pelvis for this maneuvers is not with your thumb outside. This is how you should hold your fingers and try to enter the. This video is taken from the net, and here you can see how it is taken out. It's an animated video from the internet. Next is posterior shoulder. You're not able to reach the arm. You're not able to reach the wrist. You're not able to push at the elbow, but we know shoulder is there. So you can either put two fingers through the axilla and try to bring that shoulder downwards. And here you can see an important point. The assistant is holding the head, not stretching it, holding the head away from the feet. Another method is past or posterior axillary sling, where you can fold a Ryle's tube or a catheter and pass it across the axilla and pull down the posterior arm. So when you're stuck in the space, you make use of the space. We know there's a lot of room behind in front of the sacrum. So that is the basis of rotational maneuvers. You try to push the shoulder that is on the abdomen, or you try to push it from the vaginal hand. The principle is, when you do this, either you change from the oblique diameter to the anteroposterior diameter, or you change it from the anteroposterior diameter to the oblique diameter. In whichever diameter it is stuck, dislodge from that. That dislodgement itself is going to release one shoulder. That is the idea behind it. So this is how you should push with the heel of your palm. And we talk about pushing the anterior aspect of the shoulder, posterior aspect of the shoulder. So at that situation, what is feasible to the operator? Do that. Sometimes we may have a combination of these. The idea is to just dislodge it. So here again, you can see how the operator is trying to dislodge. It is come into the, so one shoulder is come out. Yes, the other shoulder is also come out. This is delivering the posterior arm. So this is where our liberal episiotomy is going to help when we have to do such maneuvers. How much time we have. So we should always intimate the NIC also. They should be ready with the resistivity measures. Now we have this clavicular fracture, abdominal rescue and all that. Symphysiotomy, when we think about symphysiotomy, maybe this is what comes to our mind, an age-old procedure where the patient is then kept in the stirrups without moving. But we should always remember, when nothing works, this works. It is immediately you can do, you don't have to give general anesthesia or spinal anesthesia, shift to theater, or do a cesarean or savanelli and all that. You put in a catheter, put your finger inside the vagina, push the catheter to one side, palpate the pubic symphysis, cut down the cartilage. In case if you're feeling the bone, that means you are not in the midline. So you change the location and cut through the cartilage. Don't cut the vagina. Scalpel has to move to and forth, and the width that the symphysis separate should not be more than 2.5 centimeter. The assistant can hold the thighs up close by. So now we are without symphysiotomy, with the macrobots, we have delivered the baby. We are very happy, and we think that our hard work will be very sweetly rewarded, but that is not the case. Most of the times, these babies will have some consequences. So assessment of complication is important, and counseling and documentation is also very, very important. Instead of an asphyxiated baby, it is only a small Erb's palsy, which can be corrected. So that is the way we have to counsel, telling them the positive aspects rather than ending up in a stillbirth. We have successfully been able to deliver the baby. So to summarize, in shoulder dystocia, it is a macroburst with suprapubic pressure. That is the ideal first method of choice, and posterior axillary traction. Presence of mind is something we need to develop, because we cannot get a training in management of shoulder dystocia. We can only have classes like this or drills with the dummy and pelvis. But when we really meet with the situation, we have to bring all these points into our mind and act accordingly. And we should definitely have assistants and somebody to inform the patient, talk to the patient, bystanders, and a good neonatal team to resuscitate the fetus. So documentation is very, very important. Thank you all for the patient listening. I hope I haven't exceeded the time, Mitra ma'am.
Wow. I think that was just super brilliant. And you finished it in 45 minutes, Mumtaz.
Oh, great.
Imagine.
I went very fast then. Sorry.
No, but it was so beautiful. So I think, Raina, what we
Yes,
can do
ma'am.
is just let's take Dr. Bangal's topic as well, and then so that we'll have the floor open after your inputs. So
Sure,
friends,
ma'am.
बने रहिएगा क्योंकि अगला part भी बहुत exciting है, and the next and you will sit down and answer all the questions, Mumtaz. So, okay. So Raina, please invite to the
Sure,
next.
ma'am. Yes, yes. Thank you, Dr. Mumtaz. It was really a wonderful lecture, and our participants' number are increasing on this side. And I would like to now introduce Dr. Vidhyadhar Bangal, Professor and Head of OBG at Dr. Balasaheb Vikhe Patil Rural Medical College. And sir, what we read in as per the WHO intrapartum care guide, that alternate birthing positions and the patient should birth in the position of their choice. Here we're going to actually see it happen. So over to you, sir. Without further ado, please share your PPT, and yours is really everyone's looking forward to your lecture.
So while Dr. Bangal is setting up his stage, I'm really happy that we were over 365 participants, Dr. Mumtaz. That speaks of the wonderful lecture. And the next session is also going to be very exciting because we are going to witness how these things are made to happen. So over to you, Dr. Bangal.
Yeah, good evening, everyone. At the outset, I thank Dr. Mitra for inviting me to be part of this particular academic activity. I will be talking mainly on what all changes I have made or I could make in the birthing room so that many of the deliveries can be conducted in upright birthing position rather than traditional, conventional supine position. I'm working as a professor and head since last 35 years at Pravra Institute of Medical Sciences. I bring greetings. This is the institute where I'm working. And overall, just to tell you about the delivery load, maybe around 10 to 12,000 deliveries per year. This facility is a Manyata, Lakshya Manyata accredited facility. We also have International Childbirth Initiative certification, and also we work hand in hand with White Ribbon Alliance. We have implemented Loni model of collaborative intrapartum care, in which we understand the behavioral aspect of collaborative care team members, and we believe in trusting each other, supporting each other, mutually respecting each other, maintaining the autonomy, and many other important aspects. At the same time, we are providing women-centric care, respecting her autonomy, privacy, and confidentiality. Upright birthing position for natural birthing is the main theme of today's talk, and the session objectives being, let us little understand about the physiological or the historical aspects of this topic. Then we'll let us learn about what are the different birthing positions, pros and cons, and then what are the different birthing tools and gadgets that help us keeping women in upright birthing position. What is the outcome? Of course, whatever changes we make, we must have a better outcome than what we are doing at present. And how these changes can be implemented in a birthing unit. Ours is a tertiary care hospital, average around 25 to 30 deliveries taking place daily. So bringing these changes into this hospital was a challenge, but I am happy that a lot of things in last 3-4 years we are able to do it. Mitral birthing position, it's the physical posture the pregnant mother assume during process of childbirth, and it is seen from the sculptures, paintings that women used to have upright birthing positions for delivery, which is a gravity assisted and helped in creating more space in the pelvis during childbirth. There are some of the ancient birthing positions, sitting in chair, squatting, birthing on birthing bricks. So this is already there in the literature, but maybe for last 200 years, we have shifted to obstetric care rather than away from midwifery care, and all these table deliveries and supine position have come up. If we ask really women and tell her about the pros and cons of different birthing positions, we have done that exercise and more than 52% of the women opted for non-supine birthing positions. There is evidence and MRI evidence saying that 28% increase in the pelvic capacity happens when woman is in upright birthing position, mainly in squatting position rather than lying down position. When there are WHO recommendations 2018 for positive childbirth experience, and which says that women should be ambulatory and should be mobile and should adopt upright birthing position of her choice with or without epidural, but still it is not happening so. Reasons being, all we know, we are all obstetricians. Still, the upright birthing position hasn't come into our curriculum. No textbook talks about this. So there is lack of knowledge and training, lack of adequate space in the labor room, non-availability of birthing tools which help us keeping women in upright position, and of course, so-called prevalent modern delivery practices on labor table. So we tried to do it in a more systematic and quality improvement project manner, and we tried to find out why women are being delivered in lying down and supine position, and there were person-related factors, there were policy-related factors, there were certain age-old practices, and there were place-related factors. So knowing those different factors which are responsible for traditional lying down position, we had to make certain changes into the labor room, and which I started with the procurement of a wooden birthing chair, which pictures I will show you, and you will be highly convinced about different modalities that we have used. Then we fixed a horizontal squat bar to a birthing bed at the foot end. Then we purchased birthing balls and the peanut balls to help women in labor. We also created hydrolabor facility in which around 350 deliveries have been conducted in last 2 years, in which woman is again sitting in the bathtub. Procurement of steel chair with grab bar, purchase of Entonox delivery so that labor analgesia can be given. And all these gadgets are being used in the labor room, gym balls, peanut ball, birthing stool. We prepared a staircase in the labor room so that women are ambulatory and they can do little exercise, which helps us help them in the descent of the presenting part. This was the birthing chair that we have prepared, and there are different models of birthing chair, which initial was a wooden, then we made it of a steel with adjustable footrest, and then we made another version with a chair with a squat bar attached to it so that women can hold. And now last month we procured ultra modern birthing chairs, which are costing quite a bit, but all the different positions can be given in this particular bed come chair. Uh, so these are some of the changes that we have made. We also fixed a rebozo, which is a rope hanging from the floor roof of the labor table, as well as we have kept it above the bathtub, this birthing tub. We developed certain few other things which keeps women engaged into the labor room and also in the first stage when they are there waiting for their turn. We fixed a horizontal bar in the labor room corridor for birthing ball exercise. And all the changes have been made, which I will just show you. Of course, for bringing out the changes, a lot of training programs were conducted so that the team becomes more skillful. So these are the birthing tools that we have procured and put into the place. Birthing ball, peanut ball, rebozo, comfortable upright birth support, grab bar, and birthing stool. This is a birthing ball, which is used in different ways, and the picture shows how it is to be used. There is a peanut ball, practicing use of peanut ball. There is a rebozo, that is the rope, and another attachment to it. This is how the woman can hold whenever she has got a pain. On the side, you see a birth attendant and also a birthing chair. This is how even the massage can be given and the woman is kept. Ultimately, if we want women to deliver in upright position, we want to keep them in the upright position and not allow them to slip onto the all the time onto the labor table. So these birthing tools are helping us. There is a grab bar which is attached to the wall of the labor table, and this is what is seen is a squat bar attached to the lower end of the labor table. And this is a picture of a tour, labor room tour that we have started, where the pregnant women during antenatal visit are taken to the labor room and they are actually shown what all these things are so that they are oriented and sensitized towards these birthing tools. This is a picture how the woman is holding that birthing, that squat bar attached, and my residents conducting deliveries in an upright birthing position. Birthing stools have been procured, birthing chair without a squat bar. This is a steel cushion chair with a hand grip and adjustable sliding footrest, so that depending upon the height of the woman, we can adjust. This is a chair with or without hand grip. And then latest version we got is steel cushion chair with a grab bar and adjustable sliding footrest, so that she can sit there, she can hold that squat bar and push in the final stages. This is the picture showing how it is to be used. Then we have got this modern birthing bed come chair with provision of multiple birthing positions. And these are my residents demonstrating how this birthing different footrest, even the calf rest can be used. And so that ultimately we want women to be in the upright position and not lying down position. Delivery in a sitting and squatting position, holding a squat bar. We also conduct delivery in prone position, holding a birthing ball. I will show a small video clips of the same. This is a modern birthing bed with adjustable segments. And in the corridor, we have kept this long bar with multiple balls, and then women are sitting there and doing the exercises so that there is a descent of the presenting part. So thus we are utilizing the spacious labor room corridor. And we also had a dream project of starting a water birth, which we started 1.5 years back. And this has here we have almost conducted 350 deliveries. Coming to the birthing positions, in general, we divide them into two types, supine and upright. In supine, we all know what we are practicing is a lithotomy or a dorsal lying on back, semi-recumbent position, lateral position, or all four position. These are called non-flexible sacrum positions because sacrum is in contact with the surface of the table. Whereas upright birthing position, which is also called as a flexible sacrum position, and sacrum is not contact with any surface. These are sitting, kneeling, squatting position, unaided, squatting position aided, and standing position. So this is a description of these positions, how we are. Where did horizontal labor came from? The history says that during great French Revolution, one of the French emperors wanted to see his mistress delivering so that he was unable, and since he was unable to sit on the floor. His mistress was taken on the table, and thus it started from the royal family, and everybody started using this table delivery since then. Uh, there is a upright birthing positions in general, the advantages being 28 to 30% of the increased space in the pelvis. There is 54% decrease in incidence of fetal heart rate abnormalities. We all know we are all the time asking women to be in lateral position in order to avoid the vena cava compression and improving the placental perfusion. But during labor, many women are lying down in this, and we are not. Thus, that is the reason why there is a decreased incidence of fetal heart rate abnormalities when the woman is upright, because this pressure is not there. There is reduction in the C-section rate by 29% if we ask women to be in the upright position. There are also associated with lower need for epidural. Now, this is a curve of Caras which we are all aware about. And when the woman is in lying down position, we are asking her to, we are not taking advantage of gravity. Whereas when she is in upright birthing position, we are taking advantage of the gravity, and curve of Caras becomes like this. So that is the reason why we are encouraging women to be in the upright birthing position. This is a position reclining semi-recumbent. I won't go into the details of this because of the time constraint. Then what we did, how we started changing the whole scenario. We implemented or did some change ideas were tested. Then we started using birthing in chair. Then we started squatting position. Then we started one by one. We started as we developed confidence. Then we added another position, and thus we today all the different birthing positions are being implemented in my birthing room. All residents are getting trained since last 3 years. So it was actually a quality improvement project, and we did a lot of PDSAs to come to this situation, come to this status. This picture I have already shown how the women are being delivered, and this is a chair delivery. There is a good music behind this, but then maybe I'm able to hear, but it's not being. So this is the chair delivery. There is a birth attendant on the back side. She's holding the rope, and that's how she's pushing the baby. She's in the birthing chair, which I have shown you. This is how the chair delivery has been conducted. This is a squatting position, and the deliveries are being conducted in the squatting position. And this is a delivery in the squatting position.
Yes, there is a very nice background music. Sorry.
The sideline position in which the woman is in a lateral position. This is the delivery which is being conducted in the sideline position. Sacrum is free. It's a sacrum free position. One leg is lifted above, and we really practice hands-off technique. We are not disturbing the perineum, not holding the baby, allowing baby to rotate on its own. Restitution happens on its own. Only we are very vigilant, and we are trying to just assist the baby when the trunk is getting delivered. My residents are conducting this delivery. I will just go a little fast forward to save our time. Till the baby's face is pink and there is no cord around neck, we have not to be worried about the Apgar score, and the babies are delivering well with a good Apgar score. In last 3 years, almost 10,000 deliveries have been conducted in alternate birthing positions at my place. We are just receiving the baby. We are not disturbing the baby. We don't allow it to fall. This is what is called as a hands-off technique. Lateral position. This is another interesting position, hand and knee position. And these are the pictures, how the woman is in prone position on the table, and she, again, sacrum is free, and it is increasing the pelvic capacity. Even breech deliveries have been conducted into this position. And I will show you the small position I have shown you. This is the position, and this is the video. I will do little fast forward. Again, hands-off technique. Don't disturb. I'm taking little fast forward. It's a big chubby baby. There was a cord around neck. There was a hand. Woman is able to push as her both hands are touching the ground. Delivery of the anterior shoulder. We are just supporting the waiting for the baby to come out. No tears. This is another delivery in a prone position. Here, she is holding the birthing ball. I will go a little fast forward. Whenever there is a contraction or she has a feeling to push, she will hold the ball, push the ball. The birth attendant is there by the side. Gently delivering the baby, and then she will turn. Once the baby is delivered, then slowly she will turn to supine. Essential newborn care is being provided. This is a water birth. Again, I will go a little fast forward. I'm going a little fast forward. Not to disturb the baby, not to touch the baby. Once the baby is out of, the woman is not to lift her pelvis. When the trunk is out, immediately we pull the baby out. The water is warm, 37 degrees centigrade. And then we put to the breast immediately. This is delivering a birthing stool. Then we have procured birthing stools. This is how the birthing stool delivery happens. She is holding that rope that we call as a rebozo. There is a birth attendant by the side and delivery is being conducted. She has something to hold. Ultimately, we have understood that woman wants to hold something so that they can give that final push rather than in lying down position, asking them to exert against the gravity. This helps in descent of the head, reduces the duration of labor, and reduces the need for pain relief, instrumental delivery, and operative deliveries for not able to bear the pain of labor. Again, we are not pulling the baby, allow it to restitute on its own. There will be reduced possibility of any trauma. Wait, patience. Let baby come out on its own. So this is a birthing stool. Now this is something interesting, vaginal bridge delivery in prone position. This can definitely, we are practicing this in multi-gravidas at present in order to get the good confidence, and then we will immediately, we can go even to the primary gravidas. This was a case of, I will not reveal. You can just imagine what is this happening. She is in a prone position. This was a frank breech. Both legs extended, not to disturb. Let it come out on its own. Slight groin traction can be given, as it is what we do in assisted breech delivery. release of one arm, release of another arm, and then we hold the baby. Allow it to hang. What we do, take a fresh towel and then so this is assisted bridge delivery in prone position. So there are sideline positions, and then I will just show you what all things have been done. This I have shown you. All daily, all the deliveries are being conducted in these alternate birthing positions. There is a birthing chair. Intrapartum fetal heart rate monitoring is very much possible with this alternate birthing position. When she is on chair, immediately early initiation of breastfeeding can be started, and mother is quite happy. Now this is the third stage. Baby is with the mother. The resident is waiting for the placenta to deliver. Carbetocin we are using that has already been given. Similar case, second stage, third stage of labor, and this I will just skip, which I have already shown you. This is a hydro labor, some photographs. There was queries about the fetal heart rate monitoring in the bathtub, and then we have got this water, what we call it as water resistant uh, probe, and we are able to do that. So blood pressure monitoring, fetal heart rate monitoring is all possible in the water. Intrapartum fetal heart rate monitoring is possible. We are allowing and encouraging ambulation into maintain the upright birthing position, and we are taking there's a lot of experience sharing about the alternate birthing positions from these mothers. How was their experience? This was the group of women who were multigravidas with first delivery conducted in light supine position. Now they had upright birthing position, and what they said was really worth mentioning, but because of the time constraint I won't be able to do that. Now since July 22 onwards we started, almost now 3 years, and thousands of the deliveries have been conducted. What are the results? The perineal trauma with alternate birthing, soft tissue in the chair delivery, this was the chair delivery. Perineal tear first and second degree, total 6%, cervical tear 0.4, paraurethral 0.1. So they are all less than what we find into the supine birthing position. It is literature says that squatting position, although we feel that she is in sitting position, more chances of perineal trauma, but the evidence and literature says that this is the safest position for the woman to deliver with least perineal trauma. Average number of deliveries being conducted per month in different time period, chair delivery, squat, all four position, that is the prone position and hydro labor. So every 6 months we are trying to compile this, and we are finding the total number of deliveries. For chair delivery, that blue bar is going up, squat delivery, blue bar going up, all four position, uh, and then hydro labor. And ultimately then we have these different categories of women, and total number of deliveries conducted in alternate birthing position. So almost out of 900 deliveries per month, around 300 350 are going for C-section. Out of remaining 600 or so, 350 deliveries are being conducted in these alternate birthing positions, and there is uh, every quarter we are trying to see all the 10 parameters in mother and 10 parameters are in baby are being compiled, and we found that the results of this upright birthing position is much better than horizontal supine birthing position. So how we are doing it? From the antenatal period itself, we are orienting these women towards this alternate birthing position because this is totally new. Our residents and social workers and the medical officers sitting there are showing them, explaining them different birthing positions through the use of different charts, and then they are oriented to that. Birth preparedness through prenatal classes by relieving anxiety, fear, apprehension related to birthing process. We also started Garbh Sanskar for preparation of motherhood, and all the 5 pillars of Garbh Sanskar are being implemented. And now these are some of the pictures of antenatal OPD, how we are oriented, asking them to be in upright birthing position throughout the pregnancy and during labor. These are some of the classes being held, telling them different birthing positions. Yoga is also been started so that they are physically fit to have undertake those birthing positions. These are some Garbh Sanskar sessions in progress. These are the yoga for physical and mental health. It's not only exercise, but it's also fun, stress relief for the women. And birth affirmations, which we have started. We are giving these different literatures in Marathi so that they are mentally prepared, have a positive state of mind when they are approaching towards labor. We have also started nurse-led. Why I am saying collaborative care? Because we have involved nurses into the antenatal clinic, antenatal examination, and then all these orientation to the birthing tools, birthing ball training. We are telling them exactly how to use that, because that is also helping them to have pain relief in labor. Birthing ball training is being given to them by the nurses, by the medical officers, by the resident doctors, and they are orienting. Not only that, but we are showing them different birthing tools, birthing positions, bathtub. This is all a demonstration room in the antenatal OPD. Demonstration of birthing positions have been shown to them. Birth preparedness classes are shown through PowerPoint presentation, and actually we are involving them, showing them how it is to be done, how it is helpful. Not only them, but we understand that our nursing professionals should also be knowing about all this, because they are going to get it done in the labor room from them along with residents. So we do conduct classes for these nursing professionals. And one important thing what we conduct is, of course, there is a periodic meeting. This exercise step in the labor room so that they remain ambulant, the baby descends down. And also these are some of the pictures of showing them birthing positions, obstetric triage. But what I want to show you is a labor room visit. We have started labor room visit. Birthing tools are being shown. These are our nursing staff. This picture I already shown you, because orienting them, training them how it is looking like, what all facilities are there. So the group of 10-15 pregnant women are taken to the labor room, and we are showing them orientation too. They are actually allowed to sit on particular day onto those chairs, and this is a rebozo. This is an introduction to hydro labor. We are showing them how it is done. They are allowed to sit on that day into the tub so that there is orientation. They are holding that rebozo so that for the final push it is going to help them. And then use of birthing ball, how it is done, that is also being shown here, which is giving a pain relief to them. Rebozo use, squatting position, and it has all come through our some of the international midwives, those who are working in India, and we have invited them so that they could train us through these various birthing positions and non-pharmacological methods of pain relief. Skill building workshops have been conducted, and we have also gone through the literature which shows that wider pelvic diameters in upright birthing positions are there. There's a lot of literature, lot of papers, and that is how we have started this, and we are compiling all the results of alternate birthing positions, and that is with the help of many of the agencies that include International Childbirth Initiative, Japaigo, Jivdaya Foundation, Astrika Foundation from Bangalore, and of course, Women and Health Together for the Future. So I thank you all for your patient hearing, and I thank again Dr. Mitra for inviting me and allowing me to share our experiences of alternate birthing position. Thank you very much.
Thank you, Dr. Bangal. That was very phenomenal and lovely compliments for both of you. I'm so glad that we still have a good audience. And now I'm going to invite Dr. Raina, my moderator for today. So she will wrap it up and with her very, very important and pertinent observations. Over to you, Raina.
An asphyxiated baby, we have
I'm not able to hear. Is there something wrong?
is something wrong? Just a second, I'll just check my connection. Um,
Yes.
is it better, ma'am?
Yeah.
Okay. So as I was saying, ki when after a complication happens, we pat our and we manage it successfully. We pat ourselves on the back that everything went well. But then we forget, or sometimes we forget the aftermath, what happens, or how, or what psychological impact has happened to the mother. So, just a few brief words, I won't take too much time, just 2 minutes. That is navigating the unspoken wounds of labor. So, psychological trauma is real, and this is psychological trauma post delivery is real and often gone unheard. And these are three examples from my OPD. And for example, the first patient, she came just last week, and she had come with her husband, and she had a difficult vaginal birth, and she was very, very she had post-traumatic stress disorder. She was diagnosed by the psychiatrist to have PTSD following a difficult vaginal delivery. And she had come with her husband because now she doesn't want to have babies. And what she told me was that she felt she was not explained enough why it was required so much. Another patient who had a third degree perineal tear came to me and said she felt that she was not explained again. And these are all educated patients. So when educated patients come to us and they open up about the things they faced post the birth trauma, we forget those patients who are probably uneducated or who are suffering in silence, and they have problems but they don't come to you. They don't. So we need to also look at that aspect, because up to 45% of birthing individuals report birth as a traumatic experience, and up till 5%, 5 to 6% may develop full post-traumatic stress disorder, and several things like with no explanation given or a rushed communication. They feel they don't have the autonomy, or they were not involved in the decision making, because we are all in a rush, in a panic in that moment, and these things get ignored. So what can we do? As time is tight, shoulder dystocia, you just have
Dr.
a
Raina,
few.
sorry to interrupt. Dr. Raina, there is a
Yes.
request for you to from the audience to speak little louder. I just saw
All
in
right.
the box. Yeah.
Okay, sorry. So, what happens is we are short of time, and seconds matter in difficult situations. So, what can we do to overcome that? Use concise, clear language. Just say that there's a problem, we need to help now. That is one thing you can do, just in a quick moment. Take time to address the patient. Tell her there's a problem, but also tell her that she is safe, and tell her that we'll explain more soon, but you are in safe hands. Don't worry. And once the whole episode is over, offer a debriefing. Meet the family, meet the patient once after a few days, or when she comes for the next checkup. Sit down with her, explain to her what she went through, explain to her why that was done. And also, team briefings are very important, because there's a lot of loose language in the labor room happening, and this happens everywhere. So this is very important to be respectful, and here comes in the role of respectful maternity care. So it's very important to, while dealing with these emergency situations, not to lose hang of RMC, that is respectful maternity care. So let us not just be saviors and scrubs, but witness to their stories also. And thank you, Dr. Mitra, for giving me this opportunity to moderate the session. And this is the quote by Tuesday with Maury, which I am a book lover. I've read all his books. So this was a pleasure to put this. Ma'am, would you like to? This is the quote I picked up from the book.
Read it loudly.
Okay. As you grow, you learn more. If you stayed as ignorant as you were at 22, you'd always be 22. Aging is not just that you're going to die, it's the positive that you understand you're going to die and that you live a better life because of it. So I hope all of us have learned something, and all of us are going to better our practice, because I think my internet connection is stable. Ma'am, please take over.
Yeah, but I would say, Raina, तुमने गागर में सागर भरा है. So the beautiful presentations that we have enjoyed of Dr. Mumtaz and Dr. Bangal, yours was the most, a thing which all of us can forget. So we are so much, relieved with, thank God it's over, that we don't consider this. And I think you've taken your topic, which was very difficult. Friends, I must tell you that I just told Raina, you have to cover up this aspect. And I think you did it beautifully, bringing out your own cases from your practice, which are very real. So I think, friends, I am so happy today that all the speakers of the day, starting from Dr. Mumtaz, Dr. Bangal, and Dr. Raina, all three have done absolute justice to what I really wanted. And I'm really very grateful to all the wonderful, Foxians who are here to encourage us. Hamara hausla badhaya. I could see so many friends from down south, from north, from all over the country, and this is a really fantastic, validation of what we are doing along with our moderators Tuesdays with teachers is a real is accepted very well. So, Raina, congratulations, and let me tell my team. I mean, let me tell my audience that Dr. Raina just chipped in at the last moment, and you did a fantastic job. What you
Thank
have
you,
said is
ma'am.
what exactly I wanted. So I think now we can stop sharing. And this quote that you have put is very, very nice. So thank you, Dr. Mumtaz. Thank you, Dr. Bangal, and thank you, Dr. Raina. So, Amit, we can all make everybody open their whoever wants to speak. And I'm very happy to see that Vaideri, Dr. Indira, our own team is also here, Dr. Suman Bishnoi. So, anybody who'd like to add something, Dr. Bengal, people are mesmerized with your videos, and that's what I said, seeing is believing. Dr. Mumtaz, I am so proud. Somehow I knew it in my gut that you will do such a fantastic compilation of everything. And you have a lot of comments in the chat box. Amit, can you just make this even in my screen? I can only see Raina. I can't see anybody. Amit? Anyhow, any comments?
Mitra,
Yeah, I would like.
let me congratulate you for all these Tuesdays with lectures, and just let me know, how do you choose your speakers? They are so good.
This is you can see my keen eye and ear. I have
Yeah.
heard Mumtaz in
Mm,
Trivandrum, and when I
mm,
heard her talk on shoulder dystocia, I knew I wanted everybody to hear it.
mm.
And then Suman, God makes me. I don't know how I get this vision that we are going to do second stage, and I told Mumtaz you have to do, and see how beautifully Mumtaz you have explained ultrasound
Yeah.
intrapartum, really. And we had over 365 people joined us today. And Dr. Manju, Dr. Savita, Dr. Geeta, Dr. Sureka, all the professors, if they are there and would like to add, welcome Dr.
Good evening,
Arpita Gandhi.
ma'am. Indira this side.
Oh yes, Indira, तैयार हो जाओ. आपको भी
And I
करना
would
है
like
झंडे
to
गाड़ने. Last one is with you.
greet Dr. Rana also. She was AP when I was the SR in
Oh
Harding.
Hi,
wow,
Indira.
So it
isn't
was a
she brilliant?
wonderful.
है ना?
Yeah. She was always. And definitely the teachers of today were actually marvelous. I just wanted to know whether ma'am is actually using ultrasound intrapartum, because we are not using it as frequently. I mean, actually not used to use it
Uh-huh.
in second
For,
stage at least.
personally, for me,
Yes.
I'm not using it intrapartum, but I have started looking at the position of all my babies because I have an ultrasound machine. There was a comment in the chat box that the authorities don't allow. So, in my own thing, I have taken a permission to move my ultrasound to the labor room. And of course, for your own learning, you can do it. You want to fill the form and all that, do that. And as far as Mumtaz, are you there, Dr. Mumtaz? To
Yes, ma'am.
this
Yes,
question?
ma'am. We are
Yeah, please.
using, ma'am. In between, we are using.
Like we do, like I
Not
do
for
an
all
ultrasound to
cases,
see
but when we
deflex
are
head and all. And hello.
yes, please.
Yeah. Please spotlight
Yeah.
Dr. Mumtaz. Amit, please spotlight Dr.
Yeah.
Mumtaz. Yeah.
Yeah, we are using in the labor room. We have a machine there. So especially not for all patients, not when we have a doubt, we are using it.
Good evening, dear
My
faculty.
teachers like Manju ma'am, I think she's also there here in from Harding. So we have been taught that you try to make the patient push the baby, and if the head is moving by 1 centimeter, that means there is some scope. But if it is stuck and it is thick edematous cervix and loose hanging and everything, so we should keep a like a suspicion of CPD. Matlab there can be obstruction and all.
Undiagnosed, yeah.
We take a quick decision. Don't leave for a longer trial, because then there can be complications. So, but then sometimes I feel that maybe early decision for cesarean happens. And
Yeah, of course, Indira, we are all living in that era of fear of medical legal litigation. But what I loved about the way Mumtaz has taken the
yeah,
topic is that she
that
has
was
gone on to very simple fineries. Of
mm,
course, we know loose hanging cervix and delay in descent and delay in rotation and all. We are taking quicker actions. But of course, to remind ourselves of the asynclitism, and if it is corrected, then we should know what are the points when we'll be hopeful and when we will call it a day. But I think it was excellent, no? Going from the basic
yeah,
and
definitely.
yeah. So,
Thank
Good
you.
Dr.
evening,
Bangal,
dear
uh,
faculty.
I can say that
I
all the Department of Obstetrics in Dr. Bangal's, college is simply world class and very nice. It's so informative that you would want to be pregnant and deliver in that unit. It's so encouraging. So, any more comments? Dr. Manju, are you there? Dr. Savita, I could see. Dr. Minakshi, anybody would like to give their comments before? Oh, so what's the time right now?
9:30.
Oh, so we are not ahead of time. We are well in time. And thank you, everybody. So, if no more comments, but there were lots of compliments in the chat box, Dr. Bangal and Dr. Mumtaz.
Thank you.
Ma'am, one
And
question I would like to ask Dr. Bangal, if you don't mind.
yeah,
Uh, sir, a lot of comments, and even this is my query to you, ki, pelvic support, the perineal support which we give in a supine delivery, and all the videos you showed was a hands-off approach. So, how does, I mean, it's not required, and you mentioned also tears are not increased, but that's what everybody's asking. How does it work?
Yeah. So, first and foremost thing is, although it's a very blunt statement that hands-off technique, but depending upon the size of the baby, we have to decide how much to support. But if we give sufficient time on the perineum for the baby to descend and let perineum stretch on its own, then there is a adequate space for the baby to come out, and the tears do not happen. Initially, we found that my residents were not allowing restitution to happen. That's why the tears were slightly higher. But then, although hands off, I'm saying, but there are two views about giving the perineal support and not giving the perineal support. We have to be cautious about choosing both the options.
Thank you, sir.
Madam, usage of ultrasound should be a routine, I
Dr.
feel.
Samira, yeah, please come
Yeah,
again, madam.
because I'm a sonologist before obstetrician. I took my course in with Dr. Asim Koryak. As I started my practice, routinely I'm using ultrasound. My decision making may look a little early, but even today when I did my took my patient for cesarean, it was for occipital posterior position cord round the neck, and counseling the patients also will be easy, showing the patient's position, the baby position and all. I feel like that. And there were, it was a, like the, definitely it is helping a lot. So at the time of delivery, it was meconium strain like a cord around the neck, and without much strain to the patient, without much strain to everybody, with good APGARs and all.
Yeah, good, very
So
nice.
very, very nice session, madam. Thank you so much. Thank you
Thank
very
you, Dr.
much.
Samira. Thank you. And
Thank you
Dr.
very much.
Bangal, Dr. Minakshi is a professor and head of unit in Rohtak Medical College. And she has written that she wants to give a topic of thesis for alternate birthing. And Dr. Minakshi, I will put you across with Dr. Bangal. And that will be so nice that in my alma mater, Rohtak, this thing will be started.
You are
So
welcome.
congratulations to you,
Welcome.
Dr. Bangal.
Thank
You are
you.
going to
Hello,
make a
hi. Good evening, Dr. Mitra. Really, it was such
please,
a nice lecture.
yeah,
Yeah.
spotlight Meenakshi.
And
Meenakshi, please switch on your video. I would like all to see you. Dr. Meenakshi is my junior from my alma mater. Apna, ha, yes, lovely. Welcome, Meenakshi.
good evening, everyone. So, very nice lecture. It was so motivating, though we know about these positions, but since he has shown such nice videos, I'm really motivated to give patients alternate uh, positions, and they are really good. And I know in Western countries they are using all these positions.
Yes, ma'am.
So I congratulate you, Dr. Mitra. Highly motivating and very nice lectures, both of
The
them.
congratulations are for my speakers, Dr. Mumtaz, Dr.
Yeah,
Bangal,
definitely.
Dr. Raina.
Bangal sir, what
Good
about
evening, Mitra
aspiration
madam.
of
Hello.
your
Yes.
baby in the
Yeah, good
underwater
evening.
delivery?
Who is speaking one by one, please? Please
Yes,
spotlight.
yeah. Yeah, good evening, madam. Myself, Dr. Radha Lakshmi from
Yes,
Andhra
yes,
Pradesh.
welcome.
Yeah. So my question is for Dr. Bangal. So how will you decide which patient is for prone position and which patient is for supine position, sir?
Yeah. Now,
You give the patient their choice or you decide for prone or supine?
basically, we give them choice, but depending upon their choice, if we feel that she is not, which cases we are taking for alternate birthing, we are taking only low risk women. Okay, with hypertension, APH, this, that, we are not taking. Okay, previous cesarean section we are not taking. So low risk women, what we have done is birth weight below 3 kg. Below 3 kg. Initially, we did only multigravidas so that there
Yeah.
are less chances. So slowly we developed, got confidence, and now even primary gravidas are being delivered. Episiotomy we are able to give mainly in sitting position, chair, squatting position if required, but it is said that let there be first or second degree tear rather than giving full-fledged episiotomy. Since the woman is in upright birthing position and able to push, the chances or need for support as far as asking her to push too much, what we do in the supine position is not required. The incidence or the need for these ventus and forceps have reduced. There is evidence saying that for shoulder dystocia, even for assisted bridge delivery, it is the prone position is much better. Our would-be FIGO president is very much into that, and taking some hints from him, we started it, and we have started doing multis. Otherwise, till now, all the multis, even multis, we are going for C-section in bridge. Nobody wants to do any maneuvers, but it is saying that the pelvic capacity is increased by almost 25 to 30%, mainly the outlet. So we are happy to deliver them vaginally.
Yeah,
Okay.
that's what I was thinking, that if I am going to give a thesis topic, initially I would start with multis who had a vaginal delivery earlier. And
Yeah.
but to motivate them, I think maybe a
We have to
big job.
We have to explain during
Sir,
antenatal.
have you
Yeah.
witnessed any difficulty in delivery of after coming in breach, sir? Very good.
There is no
Hello?
problem with the after coming head of the breech.
In fact, I have also conducted one or two deliveries on four in breech, multi, second of twin and all. And I found that actually you don't touch the breech at all. Mother is in all four, she pushes out. And gravity helps you. You don't even have to touch the baby at all and just receive it. So
Yes.
I think now we can call it a day. Shall we
Hello?
say our bye-byes and good night? Yes.
Hello, can you hear
Who's
me,
that?
sir?
Yes,
One
Kirti.
last question, sir.
Please,
Yes,
please
please.
spotlight Kirti.
Yes,
Yes,
sir.
please.
Sir, Dr. Bangal, my question is to Dr. Bangal.
Yes.
It was a very enlightening lecture.
Yes.
My question is, sir, whatever we have seen, and I also feel that this is more practical for the rural women who are like active throughout their pregnancy, doing household works and all. How do you see that the urban women and the educated and professional would accept this type of alternate positions in during birthing? And
The birth preparedness
experience,
is
sir.
extremely birth preparedness is extremely important. They should be oriented with these physical exercise or activities and different positions that they have to take during alternate birthing position. So if they are oriented throughout the pregnancy, there is no problem. There won't be any difference between rural and urban women. But women must be told and they should be sensitized towards these birthing positions. We cannot just in the last stage when they enter into the labor room, we ask them because their knowledge is that the woman is usually delivering in a supine position. That is what is happening traditionally. But if we want to tell them about this alternate, they should be mentally prepared. That's why we are doing it. We are showing in a big sort of a television there, different positions. We are showing them, demonstrating them. We are taking them to labor room and they are mentally prepared for these alternate birthing positions.
And
In
I
what?
think that is the reason, Dr.
Oh,
Kirti,
yes,
that
ma'am.
antenatal classes is not just theory, teaching, but if they see charts and they do exercises together, it becomes fearless exercise for them. And then they are free to choose. And it all depends on how we educate or counsel our patients. We know ना, जब डॉक्टर डरा देता है कि गले के चारों तरफ नाड़ा है, बच्चे का वजन बहुत ज्यादा है, तो पेशेंट के मुंह से लगता है मैडम सिजेरियन कर दो. And we know when we want to do something, we don't want to do a hysterectomy, we want to push Mirena, we are successful. We don't want to put Mirena, we want to do a hysterectomy, we can do it. So basically, I just wanted my aim of inviting Dr. Bangal, although I knew that the topic today is already very long, but I really wanted his first-hand position because I thought I will be completing the second stage totally so that all people can actually see that what we read in books is being practiced in Pravara because of Dr. Bangal's motivation. So thank you, Dr. Bangal. You
Madam,
insisted that
I
I
want to
come
know
to
what
Pravara.
is
I have
the
one more question, one last question. Please let me
Who's
speak.
asking that question?
I am
I want
Anjana,
to,
ma'am.
I'm Dr. Poonam Gupta. I want to ask,
Oh
madam,
God, मैम
I
मेरे को
want,
प्लीज दोगे
I
आप
want to
टर्न या
ask
फिर
One by
फिर
incident.
one by one. First, Poonam.
I want to ask if there is any increased incidence of perineal tear, and in long term there are more chances of prolapse uterus. That I want to know.
Uh, Not only at my place, but even if you read the literature that is published literature in the international peer-reviewed journals, it also says that in squatting position, the incidence of perineal trauma is least, which we are not aware. Since we are not oriented to all this literature, as it is not there in our curriculum, so we have these queries in mind. But even if you see the literature, it is saying that perineal trauma is less in upright birthing position than the supine position. Second question you asked was about
Prolapse. Prolapse.
prolapse. Since the
Prolapse.
duration of labor is reduced, duration of labor is shortened, second stage is shortened, the chances of prolapse are not increased in upright birthing positions.
I
In
personally feel that prolapse is very much linked to the collagen tissue and the elasticity of the pelvic floor. And basically speaking, because the choice of patients is pretty much well done, so the tears and first or second degree tears are always, they get repaired very easily.
madam, what
Dr.
about third
Anjana,
degree
can I
perineal
ask
tear?
you?
yes.
Sorry?
What about third degree perineal tear?
No, no, third degree perineal tears are common only if you've already given a place for, it is episiotomies, which usually extend into third degree, unless you are doing instrumentation and all. Third degree
Okay.
perineal tear करने के लिए काफी कुछ चीजें चाहिए होती हैं. इतना easily होता नहीं है. But Dr. Anjana, your
Ma'am,
question, please, so then we can
yes,
finish.
sir, I want to ask you that
Dr.
nowadays
Anjana,
taking. Yes, ma'am. Can you hear me?
yeah, I can, but yeah, you are not now you're spotlighted.
Yeah. What I want to ask you, sir, is that nowadays, taking into consideration all the medical legal aspects, are you getting a specific consent before taking these patients up for these alternate birthing positions?
Yes, we have prepared a separate consent form in the local
Okay.
language and
Okay.
in which they sign that this is what they are opting for.
And are you mentioning the complications also, that they might meet all these complications while delivering?
Complications are much less than the supine position, so we need not worry about it.
Another thing I want to know, sir, is in the this hydro delivery, once the baby's head comes out, remains under the water for a pretty long time. And once it is out, it starts breathing. Then how do you manage the aspiration part?
Baby does not breathe till it is coming to the surface. Baby is not breathing, not taking any breath. That's why we are not disturbing the baby. We are not touching the baby. And once it is out of the water, then that would be, then only baby will take the first breath. Baby is
Okay.
already in the water inside the uterus. It is said that it's a smooth transition from warm water to warm water, which we are maintaining the temperature, and baby is not breathing.
Thank you so much, sir. I had these
Okay.
queries
Thank
only.
you, Dr. Mumtaz, Dr. Raina, Dr. Bangal, all the wonderful audience. अभी भी 135 लोग बैठे हैं. अगर खोल दिया तो सब अपने comments देंगे. But I don't know, I don't have words to say that Mumtaz, your understanding and your presentation both are excellent.
Thank you. Thank you.
And of course, Dr. Bangal का तो हम पहले से जानते थे. And the good thing is that we finished in time. Dr. Bangal, we finished everything in time.
Yes.
And Raina, your inputs were very thoughtful. I'm very grateful to God. And let me tell you today, friends, my WhatsApp conged off in the morning. And I was like, अब ये क्या होगा, कैसे होगा? But then, you know, everything was sorted by evening. So let's say good night to each one.
Madam, we thank Amit for his help.
Yes, Amit is of
Technical
course
support.
there. Amit Saxena, my brother-in-law, is always there. Thank you, Amit. And good night. Do log in for the next one. Equally exciting, but on a different topic. We'll be declaring it closer to the date, but the market, it's on 15th of July. Definitely, all of us will learn something new by our speakers and coordinators. Thank you. Good night.
Good night.
Amit, we can shut
Good night.
the thing.
Good night, ma'am.
Good night.
लास्ट में सब फोटोज के लिए कर लेते हैं, फोटोज तो ले लेते अपन, बट चलो, ओके, बाय.